Okay, Dr. Alan Wolfelt is back, so we ask our audience to start coming back because we have an exciting second part of this marvelous workshop. Thank you so very much, Dr. Wolfelt, for the pleasure and the privilege to learning from you again after these 10 years since I heard you for the first time here in Sudbury. And I have to share with you and our public that this is one of the reasons why I became a grief counselor myself. It was because of the marvelous workshop you gave to us here in Sudbury 10 years ago.
Oh, thank you.
So thank you very much, and back to you. The floor is yours.
Thank you so much. And again, I'm so glad you reached out to me about being a part of your conference. It's an honor and a privilege, and I'm just so thankful that we can come together today as caregivers. If there was ever a time to acknowledge grief, I would hope we'd all acknowledge it is right now. So thank you very much, and let's continue our journey. I encourage those of you who wish to either share something or clarify something, pose a question, to do that during my time with you, and I'll be sure to leave a little time at the end before I make brief closing remarks to address those issues. So thank you. So we're ready to take a look at and acknowledge some of the influences on naturally complicated grief, if you will. And this is an area where I would just acknowledge in the context of our time that I'll bring up these influences. And then if you'd like me to expand on them in any more detail in the question and answer portion, I'd be happy to do that. So some of the things that I'll look at that are contributing to the potential of naturally complicating somebody's grief can surround, one, the macro societal, socio-cultural contributors, some of which we mentioned earlier in our time together. We're always going to take a close look at circumstances of the death surround, the circumstances of the death, if you will. Sometimes people will bring into loss experiences unique aspects of their personality that just very naturally can make for more complications. The griever's relationship they've had with the person that's died, you can see how it makes sense that that's an interface with potential of complications. And again, I can expand on any of these that you so wish me to. Just tell me the number or what it is, and we'll do that in the Q&A section. I'm always going to take a look at the griever's prior loss history. Some people come naked to the experience of grief. Other people will have grief overload. I just wrote a new resource because I was having a number of people referred to me who'd gone years not had a loss, and then in a short period of time, mom died, dad died, their sibling died, a good friend died. And before they could mourn one death, they have another death. And that brings about all sorts of special needs because it can consequent in things like psychic numbing and acute aftershock. Very importantly is the griever's access to support and the use thereof. I always look at, do they have support? Is the provision of the support they define? What is their ability to make good use of that support? So we could talk at length about that being a critical factor because it relates to the very definition of mourning, the shared response to loss. Do you have support that's allowing for that? And what other stresses are going on in the life of a person? Loss very rarely occurs in isolation. The griever's cultural and ethnic background can influence. If you're in an environment where people aren't sensitive to your own rites and rituals or understanding that it may be appropriate for you to be keening, but in their culture, they're not even aware of what that is. Keening, loud, guttural, visceral sounding noises of protest. So in my book, which you'll all receive, you'll see discussions on each one of these risk factors and my perception of those. The griever's religious or spiritual or philosophical background that might influence complications. And again, I could speak to some of that if you wish. The griever's family systems issues. Some families come from closed family systems where you're breaking rules to take grief and allow yourself to mourn, as an illustration. One of the most critically important one that I'm an advocate of is when words are inadequate, have ceremony. So I'm going to look at whether there's been the opportunity to have a meaningful ceremony. And of course, right now, I just concluded a series of articles on how COVID has compromised the use of ceremony and made suggestions about additional ceremony down the line due to that. But I love to teach about how ceremony can be used. Trained for 13 years as a talk therapist, but if you have a death, I'm not going to put you in a chair and talk to you. We're going to use ceremony to initiate you into mourning. So if any of you'd like me to review the functions of ceremony that have been with us since the beginning of time, that's something I'd be happy to do as well. And then the grievers counseling experiences. I want to know what's their prior experience been. Has that been good? Has it been supportive? Or like a lady just recently referred to me who was told that you're not going to get over the death of these two children and until you quit mourning, you can't release their spirits to the heavens with all this mourning behavior. And that sadly, and fortunately is not real often that I'll hear something like that, was a prior counseling experience that was just absolutely horrible, resulted in clinical depression evolving in her life. And we had to dig out from there. So these are influences or risk factors that I document in my writings and teachings that I look at when I have the privilege of helping somebody look at what are things that may have complicated your ability to integrate loss into your life, knowing you're always changed, of course, forever. So there's an interface that I use, and I'm guided in my work with complicated grievers by the relationship between the risk factors I just outlined, the symptoms, or again, the term I prefer, the signals they present, and I'll remind you what some of those signals might be, and how those interface with 6, what I believe to be central needs of mourning. That while grief is unique, all of us across cultures and age groups, I think we can identify what people helped us understand as some needs we need to dose in order to integrate loss. And I'll again teach those to you here momentarily. As they teach me, I'm listening and learning about any or all of the inhibitions that might have evolved from complications around their ability to dose the 6 central needs of mourning in the model that I use to teach. And I would encourage you to look at other people who provide leadership in the field, their models of understanding what I call central needs of mourning. Others might, Bill Warden calls them tasks, if you will. Teresa Rando has a model. Look at what people provide and then see what resonates with your heart and soul and helps you to help other human beings. But in terms of the symptoms, let's back up a moment. Sometimes you got to go backward before forward. Remember, I'm looking at the risk factors we just outlined, the symptoms or signals presented, which I'm just now going to bring up, and the 6 needs of mourning. So the signals that they might present, which are human signals that one's encountering the need to grieve and mourn. You might be shocky. You might be disorganized or confused. All change starts with chaos. You may have elements where the world doesn't feel as safe, elements of anxiety. You may have some protest, or what I prefer to call, like explosive emotions. Anger is too simplistic because it can involve hate, anger, resentment, terror, jealousy, a whole spectrum potentially. Again, the key word is potential. Never prescribe these. You're not a grief buster. You're learning if people experience these, how to then be responsibly helpful. Someone might teach you that a aspect or dimension of their grief is regret review or issues of guilt that are part of being human potentially. And the hallmark of grief, of course, is sadness, to mention a few, not an all-inclusive list. But this is what I mean by symptoms that I'm going to go on in a moment and differentiate the normal expression of that symptom from somebody who might give me a cue that they're shining the light, that they need additional help. And related to my use of the word shining the light, it made me think of that when we had that nice comment about kids regressing. Well, that child's shining the light that they need safety. And I always think of the teaching story about the little blind boy that lived in the village. And everywhere he went, he carried a flashlight. And nobody understood why. He was blind. But one day, someone was wise enough to say, "Little boy, you're blind. Why do you carry a flashlight?" And he, without hesitation, said, "I don't carry it for me. I carry it for you and everybody in the village. A day may come when I'll wander off to the side of the road. And when I do, I'm going to shine this light brightly up into the sky in hopes that someone will come and help me get back on the path." Well, I love that teaching analogy in this context here, because sometimes people shine their light that they're having symptoms or signals that demand attention. And our role isn't to eradicate or get rid of this construct, as some people are taught. These are good symptoms to have. I highly recommend them. But sometimes you're shining that, you're putting your brights on and telling me, within this context of these symptoms, there's something we're needing to give more attention to. And again, I'll teach you about that. And then the 6 needs of mourning. Again, where's the interface? I'm looking at the risk factors. I'm looking at the signals that we just briefly introduced and how they interface with the need to dose 6 needs of mourning. Because often you'll continue to give me those flashlight behaviors until you've had the opportunity to acknowledge the reality of the death, move from head to heart. That's hard, go slow, but there's things we can do to help people do that. One of them is helping them go backward and revisit what did occur. Too many people do the opposite, try to push them forward when they may need more information to help them understand what occurred. To embrace or befriend or understand the role of how it's appropriate that you're hurting in the face of loss. It's amazing how many people think they should have some right to not have pain or hurt, and yet, you know, our capacity to love requires the necessity to mourn. And when we mourn, we're going to have symptoms of pain. Thirdly, to give honor and cherish, hopefully, not always, don't generalize that, because sometimes history of the relationship can be very challenging if someone's abused, for example. But a central need of mourning is to remember the person who died. I often say you must listen to the music of the past so you can sing in the present and dance into the future. And sometimes, again, there's an inhibition of these needs being met, so that complicates your ability to dose these needs of mourning. Fourth need, to develop a new self-identity. You know, we all know who we are because we have mirrors in our life. You might be a husband or a wife or a significant other or a best friend or a sibling, a grandparent. We all know who we are every day because of those interactions. When somebody dies, we lose a mirror. And so I'm not shocked when people need help in looking at who am I now going to be without this person that helped me know who I am. Think of the 8-year-old who recently said, "Am I still a big sister?" after her 6-year-old little brother died of a brain tumor. We're sitting out on the grounds of our center and she turns to me and says, "Feeling doctor," because that's what she calls me, the feeling doctor. "Am I still a big sister?" Well, now she teaches me that we need to give attention to that particular need of mourning and acknowledge the little brother's death, but say that when people ask you, do you have any brothers or sisters, you always want to mention Adam, because even though he's died, he'll always be your little brother. And she just smiles through her tears beautifully. The fifth need is to be able to search for meaning. I often say those who do not search do not find. And when you've been in a relationship that bring meaning, you don't wake up the next day and say, "Oh, I can't wait to go to work. Life is full of meaning." You question meaning. So that's another very central and important need of mourning. And then the sixth need is to make sure that we provide each other as humans ongoing support, not only during acute grief, but down the line, because you have those grief bursts years later where you know, who can I turn to, say, "Guess what happened to me? I saw a car drive by like my dad drove." Or I had somebody come in the office who wore the same cologne as my husband, as a lady said to me recently. And she said, "I ran to this man and said, 'You smell like my dead husband.'" And she had this grief burst, and he was a lovely man who honored her love story with her husband and said, "Oh, he wore the same cologne, English leather." There's still a few men out there, ladies, by the way, that do wear that. She had this tremendous grief burst. Even though it had been several years since her husband died, she now needs additional support. 6 universal central needs of mourning. So the carelessing symptoms, to return to them so I can teach you the distinction between the normal expression of these very healthy signals that people give us in grief from when they might give that, using the analogy of the flashlight. They shine that bright light that says, I might need some more attention because of my symptoms softening in a recursive fashion, slowly over time with no rewards for speed. It's hardening. Now, can you help me? Oh, yeah, I can. So what I'll do is bring up each of these dimensions, recognizing it's not an all-inclusive list. I'll talk about the normalcy when we have life losses of experiencing them, but then I'll show you the flashlight distinction a little bit as an illustration of when somebody's saying, okay, there's a complication here, can we give it more attention to it? Beautiful. But again, remember, they're doing the best they know to do. I don't want to term it prolonged grief disorder, pathological grief, abnormal grief, atypical grief. They're humans. And when we're humans, we need to mourn. And with what's going on in our culture, we often need help getting back on the path. So let's talk about shock. Thank God for shock. Obviously, a normal manifestation of our grief at times, particularly when we come ill prepared to grief, is thank goodness we go into shock. I always again say, thank God for it. It helps you survive. If you couldn't go into shock, you could die of a broken heart. So as with shock after physical injury, the shock of grief is protective. It insulates us at a time when we need it. We become under-responsive to outside stimuli. Our autonomic nervous system often takes over. Heart palpitations, queasiness of the stomach, dryness of the mouth. We can chill. So I could do 3 hours for you just on how do you acutely care for bereaved people when they get into shock. But let's distinguish that from when somebody might shine the light in a way that knows, I then know to give more attention to that and look at the risk factors that have influenced that shock and things like that. So sometimes, as an illustration, these symptoms can persist not just for months, but years. And sometimes there's functional value, by the way, in months. If you have a traumatic loss, you might be psychically numbed in that first 12 to 18 months. And then people will apply the linear model and think you should be over it, which is tragic. So be very careful with this information. Learn more about it. I'm just inspiring you to hopefully learn more. So in essence, a person who's sent to me years later, like a lady recently, I was asked to do a consultation on her son died suddenly, tragically, 8 years ago. She had agoraphobia. She wouldn't even go out of the house. She had 3 investigations into the cause of death that all came back with what originally was stated as suicide. And she was convinced that just couldn't be. So I go to her home and she doesn't have normal linking objects. She's got no space on any wall between pictures of her son and a life-size picture above the bed of her son. She won't use the word suicide. So that's an illustration where now it's become destructive because the central linchpin need of mourning is being able to acknowledge the death. So instead of any movement in encountering her mourning, she, in not acknowledging his death, staying in blatant denial, won't accept what's happened. And now she becomes at risk for dying while she's alive. So now that's an indicator of a complication we need to help her with, right? So another common dimension of response to loss is disorganization, confusion, searching, and yearning behavior, often combined in that context. So when we're in grief, as you all know, as care providers, we're often distracted, befuddled. All change starts with chaos. We can have trouble focusing or concentrating. Often that combines with what we call polyphasic behavior, where you start here in the kitchen, you start to wash the dishes, right in the middle of washing the dishes, oh, I forgot to finish making the bed. You start to make the bed when you remember you're reading the paper. You can't stay focused, in other words, you have brain fog. We also very naturally, often as we encounter mourning, we'll do some searching and yearning for that person, no matter what our mind goes to them. And then somebody who doesn't know much about grief, I just had a lady last week I consulted with who was told, you're obsessed with your son, you're preoccupied. It'd been 3 months since her son died, and she's searching and yearning very appropriately. So we got to be so careful. When people lack an understanding, they want to pathologize again. I remind you of that. And I think that occurs even in traditional mental health. Anyway, complicated distinction would be for people who grieve but don't mourn, instead of characteristics of mourning soften that harden, this becomes particularly true with elements of feeling confused, disorganization, having short-term memory loss. So instead of the softening, it hardens. So do keep in mind that disorganization lasts much longer than most people think. You know, some people think, oh, in a week or two, they'll go, oh no, it lasts months very naturally. So be careful with this. But if somebody's referred to me and they consistently have inability to focus, then we're looking at, oh, get the rake and hoe out, get into the compost, see what's going on. Often they need more time looking at the relationship history or the death circumstances or various things that they'll eventually teach me. Characteristics of grief do not soften unless they're converted again into active mourning, a distinction I've made throughout my time with you and one I'll anchor in your heart here in a little bit. Of course, the classic line from C.S. Lewis relates to the next signal that people often give us, that the world doesn't feel as safe. His first line again, lovely, classic book, please read it, A Grief Observed. I did not know that grief felt so much like fear. Well, yes, loss of any kind naturally creates aspect of the world not feeling as safe as it did before. People often will pose questions related to how am I going to go on without this person? If one person dies, will another? It often is an invitation to take a look at your own awareness of mortality, if you will. So those are normal phenomenon in introductory fashion. But in the context of that flashlight, some people that have struggled with particularly pre-existing anxiety, panic attacks, or fear before a loss in their life often find this dimension more complicated because they bring that into their history of the loss. We also know that violent circumstances of traumatic death often result in grief responses that splits grief into 2 parts, where you'll see PTS, post-traumatic stress. I dropped the D, by the way, again, because of my emphasis on people are doing the best they know to do. I have a whole teaching I do based on reframing post-traumatic stress as traumatic grief. But there's a two-part at times. When you have a trauma loss, we sometimes have to do trauma processing with a person before they can unfold grief into mourning. Protest emotions, or explosive emotions, if you will, of which there's a spectrum: anger, hate, blame, terror, jealousy, resentment, rage. These are common emotions of grief that are part of being human in the face of loss. But again, characteristics of mourning should soften. They also instinctively relate to how protest is offered. And I don't like this reality. I like back what I lost that I value. Never say to somebody, don't be mad. It's instinctive. It's often spiritually intelligent to be upset, particularly in the face of things like homicide, death, or sudden death of any circumstance. And I emphasize this here, get excited, because too many people will kind of do what I call, or show with my hand, they'll make downward movement messages related to, you shouldn't feel that way. And they break the rule of enter into what someone feels without feeling the need to change it. So a distinction I'd make where we got the flashlight behavior is where you have pronounced, prolonged protest, if you will, or acted upon parts of it. Then we've got issues going on that need to be given attention to. So uncontrolled rage, self-harm, extreme risk-taking, pushing people away can manifest in this form of protest, where you over-isolate and try to do it all on your own, creating harm to others or to yourself, destroying property. Those are all red flags. As we got something going on here. Since your dad died, you're now protesting continuously all the time with no softening. Then we need to get you the help you need and you deserve. But again, always remember, people are doing the best they know to do. But sometimes, particularly in this area, we have to put limits on the behavior that's getting them into trouble. Aspects of guilt, regret, self-blame, pretty human response to loss. The need to go backward and say, if only I would have, why didn't I? I should have. Gosh, I have a 3-hour teaching I do on how to honor people's if-onlys without telling them they shouldn't think or feel that. If they feel it, they feel it. It's a very common human thing to do. It's part of backward before forward. But some people, guilt, regret, self-blame can dominate. And instead of softening over time, they get self-punishing. They go into clinical depressions. This may act as kind of a quicksand in which, if you will, the griever is stuck. And so critically important to know that that's a flashlight behavior that's affecting the quality of their living. And sadness, being pressed down, the hallmark of grief, that's so authentic and natural, oftentimes in the face of a loss. How appropriate. Someone has died, we're sad. They can play an essential role, and there's usually downward movement before there's upward movement. And these force the mourner, invite the mourner, if you will, to slow down, to turn inward, which is instinctive, and to temporarily kind of withdraw before they come back out into the world. Matter of fact, historically, that's part of what we all did. You have a funeral or ceremony, you go to exile much more than 3 days, more like 2 to 3 months in the early 1900s. When you came out, you wore mourning clothes. We acknowledge the appropriateness of your sadness. We borrowed a term from the ancient Greeks called melancholy, and we said, oh, I see you have melancholy. I'm so sorry to hear that. Looks like you've had a loss. Tell me about it. And you'd walk down the street a little bit, the next person would stop you. And you had ongoing communal support for the appropriateness of your being pressed down. How appropriate. In the context of the flashlight behavior, yes, sadness and depression, they can also be debilitating for some grievers. If you have a prior history of a clinical depression or other subcategory of depression, whether that's bipolar depression or anaclectic depression, meaning the loss of nurturing support systems that can consequently being depressed. Some people have prior histories of depression that put them at risk for complications. So we want to watch and be supportive in helping them. And we also know other people with no loss history, because biochemistry can change with trauma loss. And now you find, as you do a differential diagnosis, that they have gone into a clinical depression that demands special consideration and care. And so those are examples of, and I hope I made good use of the flashlight analogy, that they're normal symptoms to have, but characteristics of mourning, very slowly with no rewards for speed, should soften over time. But when they harden, it's like that mourner giving me a flashlight behavior that says, can you help me better understand why I'm mad all the time? And often, by the way, that dynamic is you're defending against underlying hurt, pain. If you can stay mad, you can defend against hurt, the second need of mourning, befriending the pain. But anyway, more than you may need to know right now. Another thing I want to mention in this context that there's a flashlight issue is that some people will accumulate grief from life losses, particularly if there's risk from coming from a closed family system that says we don't do death, we don't mourn, we put things away, we push forward. And what happens is they've never adequately acknowledged the need to mourn. And that interfaces a lot with what I described as unembarked issues of grief, where they've come to grief, but it doesn't shift into more active, authentic mourning. Think of our 9-year-old. He accumulated grief for 30 years. It kept trying to get his attention. He had low-grade depression, difficulty with intimacy, history of addictive behaviors, until finally, 30 years later, what an example of how it keeps trying to get your attention. He went into a major clinical depression, and thank goodness for a compassionate, lovely, caring caregiver was referred to our center for catch-up mourning 30 years later. Again, remember, it's never too late to mourn. What are some of the potential symptoms in my observational research of 40 years of people referred to my center who've been carrying grief for periods of time and not seen that conversion to mourning? And again, this is observational research, but I've written about my experience with people who have carried grief, and what I'll often witness is kind of a constellation of things like natural different, and all behaviors are multiply determined. So you could never say if somebody has one of these symptoms, it's all because of carried grief. There could be other things. You could have a panic attack because of some organic issue going on, or an endocrine problem, or whatever. So difficulties with trust and intimacy are a fallout consequence of grieving and not mourning or carrying grief. Risk for evolving in, like my 39-year-old, into depression. Anxiety that evolves into panic attacks. Feeling kind of psychically numbed, kind of outside yourself looking in. Oh, irritability, agitation as a constant in your life. Substance abuse, any kind of addictive behaviors. Eating disorders, where we need more research on that relationship between even transgenerational passed down grief and eating disorders. Physiological problems, real or imagined, like if somebody's not mourning and they're carrying grief, they are frequent users often of that somatization pattern, where they're going into the doctor, helping with one thing, and they're back the next week with another. So those are potential carried grief symptoms. If I've inspired you, want to learn more, you could look at my book called Living in the Shadow of the Ghosts of Grief, Step into the Light. I have a passionate interest in my belief that it's never too late to mourn, and that because there's so many contributors these days in a mourning avoidant, emotion phobic culture that we're at risk for, where many people live in the shadow of the ghost, they carry their grief, it affects the quality of their relationships, their life, their living. We have an obligation to learn about that and help them do catch-up mourning. So now let's talk about companioning people for aspects of grief that's complicated. So first, I'd remind you that foundational to my philosophy of and professional experience in grief care, in a macro sense, the only effective way to quote and remember, in quote, treat complicated grief is to facilitate active, authentic mourning. So not assuming any mysterious body of knowledge, we're going to do some learning from the ground up here for a little bit, and then evolve into what I use as a 4-phase model of helping around complications of grief. So first and foremost, I remind you, bereavement means to be torn apart. One literal definition of bereavement, and why you'd never want to say to somebody, don't be mad, is a sense of feeling robbed, to be robbed. And then of course, another definition of being bereaved is to have special needs, which is why historically we had mourning clothes so we could identify people who were bereaved and people who weren't. Now, we can't identify those people because we've lost that communal sense and we lost death symbols. So you could be right next to somebody who's in grief and not even be aware that they have these special needs. So bereavement initiates us to grief. And grief, while we can define it in very many, very personal ways, waking up in the middle of the night, wishing you could reach out to touch someone. standing at the foot of the grave of your precious child, wishing you could hear their tone of voice just one more time. But for our purposes in teaching today, I want to remind you that grief is the internal response. The bereavement initiates us to grief, and we have all these thoughts and feelings inside. And isn't it interesting, you might be called a grief counselor when really, more appropriately, we won't see a semantic change in the term. We would be mourning counselors because we're creating conditions to take grief and allow it to become mourning. And mourning is the outward expression of grief, or grief gone public is a way to frame it, or the shared social response to loss. I often talk about how it's taking grief and putting it into action. And the beauty of mourning is there's no one way to do it. That's why we want to respect the mosaic of the world we live in, study across cultures, be so respectful of the unique ways we mourn, and not create social constructs that this is the right way to mourn and in the right amount of time and so forth. So having acknowledged that reality, people often will say to me, well, Alan, you teach about grief becomes more. How does that mourning help us integrate loss? So let me in introductory fashion address that a little bit. Authentic mourning, and the reason I say authentic is if you aren't authentic in what you share, let's say you had a abusive relationship with your parent and you try to acknowledge that they were wonderful, you will not integrate loss unless you can be authentic and find safe people where you can say, well, I might have loved somebody, but I didn't like them, or I didn't like these behaviors. So I really want to emphasize mourning must be authentic to be able to be integrated into your heart and your soul. So authentic mourning results in change and movement. There's a fancy word, you don't need to remember it unless you're going to be on Jeopardy. The word is perturbation, and it means the capacity to experience change and movement. If you're in grief and you convert that to the ways in which I define mourning, of which there's no one right or only way to do. Matter of fact, my favorite thing to do is get to know you and match up ways for you to mourn that fit with congruence of who you are. Don't tell everybody they should journal. That's the last thing for some. Don't tell everybody they should go to a support group. You're always trying to say, is this a person going to mourn well in the ways that we create for them to do their mourning? So I first got to get to know you, then go to my toolbox and match up ways that are safe for you. Always think about safety. So perturbation. Mourning allows for the capacity to experience change and movement. Now, how does that occur? Thank you for asking. The word feeling comes from the Indo-European root word. It means to be touched, to allow yourself to be touched. So it's in experiencing our thoughts and feelings, recognizing unique personality differences. Some people are more interior mourners, some are more external mourners, and so forth. We acknowledge that. It's in experiencing thoughts and feelings that you activate your capacity to be touched and changed by experiences that you encounter along life's path. What's interesting about it is people get that about attachment or love. You meet somebody and you're touched by them. You want to get to know them more. I always love to learn the beginnings of love stories where people talk about how they were touched by giving birth to their child or meeting this person the first time they ended up being involved in a connected relationship with, which is important if you're a grief counselor because you spend a lot of time backward. 80% of my time is spent backward with people, by the way, little sidebar for you. So we get it about love, and then somebody dies and people come along and say, well, he lived a good long life. Be glad he lived as long as he did. Carry on, keep your chin up. God, we give you these cliche messages that don't invite you to feel, but invite the opposite of that all too often. So here's the reality. To integrate grief into your life requires that you allow yourself to be touched by what you've experienced. That's why I'm very concerned with this recent trend where we move from funerals to then memorials to celebrations, and now in some areas of North America, when he dies, we'll just throw a party. You know, if you have a birthday, throw a party, invite me, I'll come. If somebody in your life dies, have a meaningful funeral experience anchored in the functions of why we've had ceremony. As we've lost an understanding of grief and the need to mourn, we're trying to be happy at times, my friends, when we should be befriending our sadness in community, remembering the words, blessed are those who mourn, for hopefully they'll be comforted, but not always, unfortunately. Remember my rule of thirds. So to integrate grief means that we have to allow ourselves to be touched. Because if we can't feel, our feelings and our thoughts when we have loss, then you become closed in your ability to be changed by it. There's no perturbation. There's no change in movement. Instead, again, in lay terms, you become stuck. And sadly, I firmly believe that all too many people today, through no fault of their own, are kind of invited to be stuck. If you throw a party when somebody in your life dies, that's an invitation to start out being stuck instead of facilitating your grief into mourning. Now, let's anchor that mourning is normal, it's necessary, but sometimes a mourner can become stuck in the wilderness of some complications that might tie to those risk factors. And then they'll use those signals to indicate, can you help me figure out why I'm stuck in a dimension of loss? Or they have an inhibition around the central needs of mourning. So I just want to remind you, emotions, thoughts, and feelings, while unique to the personality, feelings have one ambition in life. Guess what? To be felt. I often say, emotions want motion. When we deny, we inhibit, we defend against our emotions, guess what happens? Our pain lasts longer. Think about it. You want to get really depressed, be depressed, and try to act like or project to yourself and the world around you, you're happy. While there may be a place for CBT, it's not when somebody dies where you tell yourself to be happy. Actually, you'd be better off telling yourself, how appropriate that I'm sad. So I'm going to say it again, because I see too many people who deny they're depressed, and then they get chronically depressed. So if you want to get depressed, be depressed and deny you're depressed. Now you really get depressed. We've all heard that classic cliche, and it is a cliche, time heals all wounds. But I say in my writings, the integration of grief, it waits on welcome, not on time. Again, think of our 39-year-old who was 9 when mom died of suicide. 30 years had nothing to do with integration of that loss into his life. It waits on welcome, not on time. Eliminate from your vocabulary, time heals all wounds. No, only if you actively and authentically mourn. So now that brings us to the foundations of a companioning model versus a treatment model that I just want to introduce to you, because that's what undergirds everything I do, whether I'm working with somebody to support them in their grief and they're doing beautifully, or whether I've been referred somebody who has some complications that call for a more therapeutic orientation. I'm still using my companioning tenets. So let me be brief, but importantly, introduce the undergirding tenets of the body of work that I do. And that is, and again, take what you want, leave what you don't. That's the beauty of continuing education, is it? But if you need a test, let me know and I'll send you an essay, exam. A little humor there. We need that. So treat versus companion. Treat comes from the Latin root word tracture, literally, look it up, it's right there. And it means to drag. Well, there are things in life you might need treatment for. But grief is not, I believe, one of them in this literal sense of definition. Think about it. Patient means passive long-term sufferer. So take somebody who's come to grief and think of a model out of the biomedical model that you're going to treat as a patient. To drag a passive long-term sufferer. That's the last thing a mourner needs. So while I love my 13 years of academic education as a clinical psychologist who specialized in thanatology, I found that it was real different to go to school and learn the model of homeostasis, and my goal would be to resolve somebody's grief with my hands-on day-to-day experience that started in my teens, when after the death of my best friend Phil, I discovered a calling. I was going to be an architect, by the way. I like to think I help rebuild lives. But at 16, I wrote a mission statement. I'd have a Center for Loss, wrote my first book at 19. People started to invite me to support them in grief. What a privilege. And I learned there's a real distinction between companioning somebody versus treating them. See, companion comes from the Latin root word com for with, and pan for bread, with bread, a friend and equal. My friends, my colleagues, there's nothing more co-equal in life than death. Therefore, it calls out for the use on our part as caregivers of co-equal models, not I'm the doctor and you're the patient. Companioning is not about assessing, analyzing, fixing, or resolving another person's grief. Instead, it's about being totally present to the mourner and abiding in the initial fellowship of hospitality. All helping begins, I believe, as Henry Nouwen taught us years ago, in the foundation of hospitality. And how did he define that? Which I've expanded on in my book called Companioning the Bereaved, a Soulful Guide for Caregivers. He inspired me to write an entire chapter from this quote. He said, the creation of a sacred space where the stranger can enter and to become a friend. That's a co-equal model on which doesn't dismiss our need to have a body of knowledge and helping skills and be congruently matched. But I love that definition that all helping starts in the foundation of hospitality. I remind you, hospitality is not about trying to change people. It's offering them space, in fact, where change can take place. If you take grief, you facilitate it into active mourning on your own part, if you will. Again, I'm responsible to, not for. You will see change take place. I've witnessed it thousands and thousands of times in my 40 years as a caregiver. A central role of a companion is related to the art of honoring stories, which again, if we look socioculturally, there's risk that we've lost the art of retelling the love story. I call it the awesome power of retelling your love story. Honoring stories requires that we slow down as caregivers, that we learn the components of deep listening, and that we facilitate, which means to make easier, make easier the hard work of mourning around the 6 needs: acknowledging the death, befriending the pain, remembering the life, developing a new self-identity, searching for meaning, and providing ongoing support. Ask yourself, do you like to hear how people meet? I say with humility, I think one of the reasons I love grief counseling is I get to spend a lot of time learning people's love story backward. But you have to ask yourself, is that genuine? People know if you're not genuine. I don't understand it myself. I have an abnormal interest in learning, how did you meet that person? What's your relationship been like over the years? That's so helpful. Awesome power of telling the story. Not moving people quickly and efficiently forward, but inviting them to go backward as they smile through their tears. Many people, and I don't say this to shame them, but when you grow up in an emotion-phobic culture around loss, you can lack an understanding of the role of hurt, pain, suffering even, in integrating loss into life. And the consequence of that, they're more drawn to wanting to treat, to drag away instead of enter into the pain. So a central premise of a companion model is enter into what someone feels without thinking your job is to change it. So if you tell me, I'm having words with God, well, that speaks, you have a relationship with God, and that's where we're going to start. We're not going to say, now, you know, God loves you, and why don't you get in there to your faith community? And no, enter into companion, not treat. The beginning of doing that is anchored in making use of a teach me model of caregiving, that while I have an obligation, going back to our ingredients, to have self as instrument congruently matched and have core conditions and body of knowledge and helping skills and self-care discernment, everything I do, everything I encourage you to do should be anchored not in us projecting expertise onto somebody at end of life or in bereavement care, but to use a teach me model of understanding. Every person I have the privilege of being present to has something to teach me. So I never want to assume I've arrived and I'm a grief expert. That's frightening to me. The reality is, if you perceive yourself as an expert, you create pressure on someone to be a patient. And I've already addressed the concept or the definition of patient. So you want to begin by clearing your mind. I would submit to you, opening your heart. So let's just clear the space for a moment, and then I'll invite you to develop, as I've done years ago, a ritual of reception before you see anybody. It could be different from my own, but as someone who loves to mentor people into this area of caregiving, I would simply take a moment and model that years ago. I take 2 minutes before I see an individual, a family, child, adult, and I out loud say, over that period repeatedly of 2 minutes, no rewards for speed, not attached to outcome, divine momentum. That clears space for me to then receive that person, create a holding environment anchored in hospitality and sanctuary where they can disengage from normal demands and give attention to the need to take that grief and allow it to become mourning. Now, somebody out there is saying, why those 3 things? What do those make sense to you, Alan? Well, no rewards for speed, because grief goes slow by nature. It calls out for convalescence, which means something that's recursive and slow. So I don't want to use some solution-oriented 3-session thing to get rid of symptoms. You have the symptoms for a reason. No rewards for speed. Not attached to outcome comes from my time 30 years ago. I'd already been writing about, we don't resolve grief, we reconcile it. I was invited to do a lecture tour in Japan. What a privilege, 30 some years ago. And between cities I would go to speak, I would visit doshis in Buddhist temples, and they'd say, "You Westerners, you're too attached to outcome." And it just resonated with me, because my job isn't to resolve people's grief. It's to create conditions where they actively dose the needs of mourning, and in order to integrate it and be transformed, they reconcile. I believe, I wouldn't do what I do if I didn't believe you could reconcile loss, which means to make your life good again. But the more attached you are to outcome, like I got to get this person let go, the more they will end up saying, "I'm not coming to see you. I'm going to a support group where I go next Wednesday, say the same thing I said last Wednesday, and nobody says, 'Shut up, you said that at the last meeting.'" So that helps you. It helps you. It's kind of a homeopathic approach. You back off and let them come to you, and you're not trying to treat them in that sense. And then divine momentum. Well, I think, I spend an hour, 2 hours with somebody, and then they're back out there in the world. I'm hoping I'm creating momentum for them to keep doing what they're doing. Or a common example of that is when I give public programs 60, 80 times a year, public evening, couple hours, I'll have a line form at the end, and people will come up and they'll say, "Well, I wasn't sure I wanted to come tonight, but I'm glad I did. I learned I've been grieving and not mourning." And then I hold the mirror up and I say, "So what have you learned tonight that you might benefit from doing?" And they go, "I need to commit myself to mourning, because you're teaching me, that gives me hope, and it'll make a difference." And when they say that, I've created divine momentum for them to take their grief, allow it to become mourning. Beautiful. No rewards for speed, not attached to outcome, divine momentum. Create your own ritual of reception that helps you create sacred space for your fellow humans. So here's a few of my 11 tenets. I think I put 5 in here in the context of our time, but if you go to our website, you can print out my 11 tenets or read any of my books. They're generally in there. Companioning is about, 1, being present to another person's pain without taking away the pain. That'll take you a long way in life. Too many people think, "Oh, I got to change what this person's experiencing." No, there's a concept many of you are familiar with called phenomenology. My reality is my reality. And the more you can empathize with my reality instead of bringing your external reality to me, the more you allow yourself to be taught by that mourner. Companioning is about listening with the heart. It is not about analyzing with the head. Heart, well of reception. Yes, there's elements in your body of knowledge where you've got to learn it and it feels heady and intellectual and academic, but never, my friends, lose your heart. Companioning is about bearing witness to the struggle of others. It's not about judging them or directing them. I'm responsible to people, not for them. Yes, I hope you have advocacy as one of your interjects in life to go out and help others learn more about end of life and grief care like we're doing here at this conference. But bear witness. People are in liminal space often. They're betwixt and between. Think of the image of 2 rooms, and between the 2 rooms is a doorway. You're in neither room. That's what grief feels like and is like. And it makes sense people want out, but your role isn't to pull them out, isn't to fix them or take the pain away. Ask yourself, can you congruently be present to people who are in liminal space? Because when you're with people in grief, they're struggling. And if you try to fix them or pull them out of their liminal space, you become harmful as opposed to helpful. Companioning is about being still. It's not about frantic movement forward. Some of your most sacred times with people are in sacred silence and stillness. That little girl I thought of who said, "Am I still a big sister?" We'd been sitting there for 10 minutes outside our sanctuary of the Center for Loss, watching deer. And out of that 10 minutes of silence, she looks at me and says, "Am I still a big sister?" If I'd have been filling every void with words, she never would have felt safe to bring up that she needs some help dosing that 4th need of mourning. Who am I now going to be without my little brother? Companioning is about respecting disorder and confusion. Oh, that's inherent, as we said, short-term memory loss, brain fog, polyphasic behavior. It's not about imposing order and logic. So mourning is anchored in love, not logic. You can't think through grief. Don't shame people who try, but find ways to join them before you move them. So my professor who came in and said, what will be the intensity and duration of the experience? I gave him articles to take home and read and said, now, when you come back next time, we'll discuss the implications of the findings. He said, I love this. People keep trying to get me to go to a support group, and they were mismatching him. So I knew it would be slow, but him and I, we could academically engage and think through and discuss the literature and all that stuff. And then slowly over time, I found ways to help him get to the underlying love and attachment to his wife of over 50 years that he needed to mourn. Go slow, no rewards for speed. And last tenet in the context of our time I share is companioning. It's about compassionate curiosity. It's not about expertise. Do you have a compassionate curiosity about people's lives? Can you, as someone is actively dying or someone who's bereaved, can you be curious to learn more about their life and the journey they've been on? Is it anchored in your compassion, your natural empathy? Because if it feels like too much work, it probably isn't, and you may be mismatched. But I hope you have compassionate curiosity to learn things like, what was their relationship like with this person that died? Have they had support? Did they access ceremony? How does your own unique personality influence this journey you're on? If you do it and it's genuine and it's anchored in heartfelt compassion, they'll be more than happy to often teach you. So with companioning, I think anyway, that the beauty of it is that it becomes more one of discovery instead of recovery. I like to frame it that way. I get to get into the compost of people's lives with my rake and hoe. Sometimes I need a shovel with complications, but it's a process of discovering and then creating a care plan for them that helps them integrate loss into their lives. I remind you that companioning is about the need to acknowledge each other as equals, not as doctor and patient. You know, regardless of your years of education or socioeconomic, some of my best caregivers I've trained are lay caregivers who can operate from that co-equal model. And that's not to dismiss those of us who've dedicated our lives to learning a body of knowledge, but always consider that there's nothing more co-equal than death, and to operate from ways of being that allow that person to be the true expert or your teacher. What makes us equals, we might ask? Well, we're all human beings. We all, if we live very long at all on this earth, will come to know some pain and suffering that comes along the path. And you know what, at bottom, we all need each other. We all need each other. You see, companioning each other, we want to ask ourselves at a foundational level, what do we need to observe? Because all helping starts with observance, which means literally to watch out for, to keep in honor, and to bear witness. What are the areas I would encourage you at a foundational level? If you want to be a bereavement caregiver or already are, take inventory if you have mysterious body of knowledge in these areas. And that is, we have a responsibility, I believe, to use a holistic model that knowing when somebody's bereaved and torn apart, they're affected in 5 areas. They're affected physically, cognitively, emotionally, socially, and spiritually. So in that context, we could spend a day on each of those 5 areas, increasing our mysterious body of knowledge to know that when somebody's torn apart, again, we have a responsibility to know about things we can help them care for themselves in the physical realm, cognitive, emotional, social, and spiritual. We have an obligation, if we're going to be able to affirm people on the path to integrating loss into their lives. And that's a sequence issue, by the way. This body of knowledge allows you to affirm people. Where many people get into trouble that may not have that body of knowledge, no fault of their own, is they'll try to transcend somebody before they affirm them. So another thing to put up on the wall somewhere is affirmation sequentially precedes any ability to integrate or transcend loss. So if you come up and try to transcend me, but you haven't affirmed me, which is what's happened in our mourning avoidant culture, we tend to forget the sequence and we transcend by, let's throw a party, for example, instead of have a funeral that affirms your right to be sad. How ridiculous. We have an obligation to know about unique shapers of grief. Among them are things like, again, the history of your relationship, the circumstances of death, have you had support, your unique personality, the unique personality of the mourner, have you accessed ceremony, gender differences, cultural differences, the list goes on and on. We have an obligation to know about good grief mourning signals or symptoms, if you will. Again, I prefer signals. Like disorganization, protest emotions, regret review. Boy, you need to study those in depth because those are the flashlight behaviors that people give you. We need to know about and integrate into our heart and soul those 6 central needs of mourning. Because every day that's people give me cues where there's been an inhibition. Nobody's given them the information they need about the death. So the linchpin need of mourning is inhibited, acknowledging the reality of the death. Or maybe they come from a family where they deny pain. So there's an inhibition on the second need of mourning, befriending the pain of the loss. Maybe somebody's come over and prematurely removed linking objects or told them to move or to put the past in the past. And now there's an inhibition on the third need of mourning, the need to remember the person who died. The list goes on and on around those 6 needs. That's your helping role job description. Please aspire to just integrate them into your being so you don't even have to think about them when people give you cues. And then we need models today because of what's happened and what I've already talked about in my time with you, where we're seeing kind of the natural evolution of a lot of complications of grief, which are a result of living in a mourning avoidant culture with short social norms, where you're greeted with buck up messages, where we've lost death symbols, where we're throwing parties instead of having funerals. The list goes on and on. Whenever grief is naturally complex, as I now focus on and introduce you to the model I use around helping people with complications of their grief, the grievers need to mourn, and the means of effective mourning just naturally become more complex. So let me, if I could, introduce you to my companion model in the context of when grief is naturally complicated. So in a broad sense, I use a 4-phase model. And the first step in that process is to have them teach me. I spent a lot of time initially getting into the compost and looking at those things that can potentiate complicated mourning that we call risk factors, right? Earlier identified. So I'm going to identify and acknowledge some complication. I have nothing to hide from the person. I'm going to say, you have unembarked mourning 30 years ago when you were 9 years old. You were in a closed system where your mom died. And because of stigma around suicide, the family rule became never use the word suicide. Your dad remarried quickly, you moved, all linking objects. I'm going to explain that. And I'm going to say you were set on a path of grieving and not mourning. In other words, no matter what subcategory I use in my framework, I share that with people. I don't have anything to hide from them. And I have a series of forms I share with them. It's a PDF available even on our website in my training of other caregivers. I'm going to openly, as the first step, frame up the challenges. And I'm going to use terms at times like you have impasse grief or you're off trail here or whatever. And I'm saying the beauty of it is we can help you get back on trail. Here's some of what we might do. But the second step is having empathy for the resistance to do the work of mourning, because many times for years, people have been invited to go the other direction from their grief and mourning. So you don't flip a switch and go, oh, okay, now I'll just start mourning after 30 years. So have a lot of empathy and go slow and remember those no rewards for speed and guard against this tendency, as we've confused efficiency with effectiveness, to use short-term 3-session models where we try to think through loss or solve their issues or get rid of symptoms. That is a mismatch for the hard work of grief. Sorry, I got too excited there. The third step is to then create a care plan whereby somebody's helped me understand where there's been an inhibition around the 6 needs of mourning, which I'll bring back up to just remind you briefly. And that's an anchor for me in how I'm getting a sense of direction that they provided to me, because it's mourner-led around the 6 needs of mourning. They need more help in knowing what happened. They need help in understanding it's okay to be in pain. They need help doing memory work that may have been inhibited. They need help in looking at who am I now going to be? Because people have told them, well, be glad you had him 50 years, but they're sitting there struggling. They're calling me a spider and I don't like it. Like a woman said to me recently, a widow. Everybody said, you're now a widow. You can sit in this row at church. You can sit in the widow's row. And she's going, but I don't want to be a spider. And there was a complication around her ability to work to develop a new identity that people wanted her to immediately take on. Go slow. The search for meaning need, one of the naturally slowest needs. You don't quickly do it. It's slow. It's arduous. It's called the work for a reason. And then to receive ongoing support, because those grief bursts will come years later. And you need to know, who can I turn to even years later to get some additional support? And then fourth step, in a broad sense, is helping through the dosing of those and the framework of the care plan to help them integrate it into their life, knowing they're still transformed forever. It's not like waving a magic wand, it's slow. But my ultimate helping goal is not resolution recovery, it's reconciliation. It comes from Middle English, to make your life good again. If you mourn well, you live well, you love well. Now again, that's a very brief introduction to a much broader topic of the 4 major steps I use in helping somebody where there's been things that have complicated their grief. As noted, active mourning is the key to being able to integrate or reconcile loss. So I emphasize here that the 6 needs are the heart of the process that I make use of with someone who's come to grief, whether it's complicated grief or uncomplicated grief. It's just that with complicated grief, there's more inhibitions that have often now taken place around the 6 needs of mourning. But those 6 needs, they're the path, they're the fuel to integrate and to reconcile loss into one's life. Because complicated grief is grief that's been stuck or off trail, helping a griever create healthy momentum comes about through judicious, and I want to emphasize this purposely, griever-led dosing of those 6 needs of mourning. I think it's a very effective model. That's why I mentor and have a training center to train other caregivers in it to help companion people into integrating loss into their life. Again, there's those 6 needs. You want to work to, and I'm purposely revisiting them in this brief presentation with you to just let you know, think of this as your helping role job description. Every day, people give me cues. They need help in dosing these 6 needs of mourning. And again, purposely repeating the interface, I'm guided in my grief work with people with complicated grief by the relationship between the risk factors I outlined, I believe I gave you 12 of them, the symptoms they present like shock, disorganization, protest emotions, etc., and the 6 central needs of mourning. As they teach me, I attempt as best I can to listen, to learn from them in an attempt to create a care plan where we can look at any and all the inhibitions around one or more of those central needs of mourning. And then what an opportunity to go forward and to help them with those 4 phases. As compassionate companions, we must discern which one or more of those needs they need to help with in terms of encountering it. It then becomes our responsibility to help dose the griever with those mourning needs that correspond to their symptom-specific unembarked grief potentially. Maybe their impasse grief, maybe their natural invitation to have gone off trail, or maybe at times even encamped grief. Yes, what a privilege to help people take their grief and allow it to become mourning so they can live fully until they die. Here's the challenge. We have more and more people struggling with complications of grief. We shouldn't be shocked by that if we take a look at those socio-cultural contributions, contamination of the medical model of grief care, if you will, and other contributors. We have more people struggling with complications of grief, I believe, than we have people trained to know what to do with help them. One of the biggest things that you see is over-normalizing grief when it's complicated. Oh, I'm not eating well, that's not eating well, that's normal. Not sleeping well, that's normal. I thought I saw him from behind. I wanted to walk out, well, that's normal. Well, if it's also normal, what am I doing here talking to you? More commonly, people have complicators contributing to their grief that we need to give attention to. So the most beginning level grief counseling area witness is over-normalization that minimizes some aspect of where there needs to be given attention to some complicating thing, where they've been seen twice, told they're normal, and they don't go back, and now they're still carrying that with them. Let me make a distinction. For some of you, appropriately so, you are a grief support person, and you provide education, support, time-limited follow-up to families potentially through the hospice that you may work for. There's a lot of focus, not that there isn't focus on backward work, but you're probably not doing grief work from 30 years ago. And there's a lot of emphasis, appropriately so, while you don't minimize it, of normalizing what they're going through. But when we get into complications, then we're over in a psychotherapeutic model that often is slow by its nature because this complication doesn't get uncomplicated quickly, efficiently. So it's more anchored in being reconstructive. There's an emphasis on the depth of what somebody might be teaching you. I often have to do interpretation to them about why this has evolved for them based on what they taught me. There's a lot of a need often to go backward. That's okay. And there's a lot of emphasis on those contributing factors that have complicated their grief. So know when to refer. It's appropriate. Many people need that support and that counsel. But if you run into somebody who were a death occurred 30 years ago and they're struggling, then maybe you want to consider the potential of referral. Again, the best thing of any caregiver to know is when to refer. My friends,
sorry, Dr. Wolfelt, sorry to cut you off. We have a little less than 15 minutes left, and we've got about 18 questions. So I just wanted to give you a heads up.
I appreciate that. And what good timing and instinct you have, because what do you see up on the screen? A final word. So I will close briefly, and then I will allow for, or better yet, let's do questions and answers. And then if you give me 3 minutes to close with, I'll do my final word, okay?
Okay,
So
perfect.
let's do that. You got 18 questions. That's great. Thank you, folks, for your engagement and what I'm sharing with you. So shoot them at me.
Okay, so there's about 4 that have to do with the pandemic. So the first one is the numbers of people who have had to die alone without family during the pandemic has been significant. As well, due to pandemic rules of gathering, families have not been surrounded by support by traditional means. Should we be expecting more complicated grief? As well, professionals are experiencing compassion fatigue and burnout at alarming levels. It seems like a perfect storm. Any suggestions?
2 separate questions there, but let's go to the first one.
Sure.
I've written extensively, and I'm going to answer the question, but I've written probably 20 articles about COVID and grief and its complications surrounding issues of ceremony. So the question of, because people have had all these inhibitions around not being able to, if there's ever a time, as we all know, to be present to someone we love, it's when they enter the transition from being alive and living to dying. Secondary to the restrictions of COVID, for many people that hasn't happened. Also, there's been inhibitions around the capacity to experience ceremony, to initiate people into mourning. So I've written a lot about, yes, we're set up for complicated mourning if we don't create care plans. Like this is a case where one ceremony is not enough, where you're limited to 10 or 15 people and it's short, and all those things that have complicated grief now set us up for an epidemic of complicated mourning and people who've experienced COVID deaths because of restrictions and other things. So I've written about how this is an example, for an instance where one ceremony is not enough. So with COVID families, we're going to use 3 ceremonies spread over a minimum of 2 years to revisit the functions of ceremony, because there has been a restriction in that regard. So if we know the functions of a ceremony are help you begin to acknowledge reality, recall the life, activate support, express grief into mourning, and establish a context of meaning, those functions have been compromised. So these families need caregivers who are aware that this is an instance where when words are inadequate, you use ceremony, but one ceremony is not enough. So an illustration I give you, I've written about, you'd find on my website in my COVID articles, is I advocate for 3 ceremonies, minimum, spread out over 2 years, and when restrictions are lifted, have ceremony where you can activate that support and revisit those functions that I just in passing mentioned. The second one, gosh, I just wrote a handbook on self-care for caregivers related to some of the complications of COVID. So, you know, call it what you want, burnout, compassion fatigue, vicarious traumatization. Yes, all the conditions are present for all of us as caregivers working at this time for becoming wounded healers if we don't have discernment about self-care. So as hard as it is to do, find forums where we can put that at the top of the list. Often self-care gets knocked down to the bottom, or we do it at an hour at the end of a conference. Right now, it should be right there at the top of a list, or we should have conferences dedicated to discernment about creating self-care plans. How do I identify in ourselves and others that we have flamed out? What are self-care practices that we can do despite the challenges that we have? Huge separate topic, great workshop topic, one that I enjoy teaching. So 2 questions are inherent to those words you shared with me, but let's go on for the purposes of time to maybe a couple more questions before we need to close.
Okay, thank you. As the pandemic continues to affect us globally, many families have not had the opportunity to attend their own family's funeral and just to say goodbye. So how can we begin the discussion with the family who has not started to grieve?
We can have awareness in our body of knowledge that this is a family who's giving a cue. They're going to need more ceremony down the line because there's been an inhibition again around the functions of why we have ceremony. And what are those functions again? That family's just given a cue. There's been a lack of ability to acknowledge the death, to befriend my pain, to remember the life, to develop a new identity. Think about in the pyramid of my why, of why we've had funerals across cultures since the beginning of time. We have funerals because they help us begin to acknowledge a reality. They help us recall the life lived. They activate support. they begin to express grief into mourning, and they establish uniquely to our family or our culture some sense of meaning despite the fact that someone has died. When there's an inhibition of that, which we've witnessed during the pandemic, people are on hold. But grief doesn't wait for hold. It's still in you, but it needs to be converted to mourning. So then we creatively, as caregivers, find ways, as I've already mentioned, to invite people to do that. And so we're going to need more and more ceremony. So for those of you trained as ritual specialists or celebrants or chaplains who can help people with ceremony, one of the implications of this question is it's a time to step into your role, be a gatekeeper about the value of ceremony at a time when we're de-ritualizing, and know that right now, people have realized often when they can't have something, they value it more. So here we had this pattern in North America of de-ritualization, and then we inhibited people from gathering at a time of death. And now they're going, oh my goodness, I can't articulate why, but maybe these funerals are important. Maybe we shouldn't throw parties. So another implication of that is we need to do more education about how ceremony helps us know what to do when we do not know what to do. And the pandemic has influenced that. And now we have an obligation to create more learning opportunities for people to learn the function of ceremony, to become ritual specialists, and help people, when words are inadequate, use ceremony to take grief and allow it to become authentic mourning.
Thank you.
Maybe one more, then I'll make a few closing remarks. One more, maybe out of your 18.
Sure, let me just roll down here. I've got a few to choose from. Somebody was mentioning that they've heard that groups are not as helpful, but I can't quite find the question.
Well, let me say something about that. Always pre-screen people for groups. And if you're going to do groups, don't go, you seem to be a caring person. Next Wednesday night, we'll make you the leader of the group. You have an obligation as a caregiver with a distinction between closed-ended groups and open-ended groups, how to pre-screen groups, how to deal with difficult participants, what are your leadership description of your role, all sorts. I do a 4-day intensive seminar on support groups. So I appreciate that you just gave a cue about not everybody does find support groups helpful, and that's why we need to pre-screen. So the professor that comes in, what will be the intensity? You want to ruin your group? Put him in a support group. I detest when people say everybody should go to a support group. No, they shouldn't. You should pre-screen them to see whether that's going to be a safe place for them to be an effective member of that group. And then as leaders, take on the responsibility to know it's pretty sophisticated to be a good group leader with grief. And you have an obligation to learn the body of knowledge. What are group counseling skills that you need? How do you do a consensual validation? Many people do groups, they never even know what that is. But obligation, learn about pre-screening, learn about the difference between closed-ended groups that you graduate into open-ended groups, all sorts of good stuff in the body of knowledge about support groups.
Okay, and do you have time for one more?
What do we have, about 5 till the hour? I need about 3 minutes to close. I bet we do. I'll just try to be concise, even though I love to teach. I'll just be concise.
Okay, great. Alicia asks or says, I've been hearing this term called unalive. Is that an acceptable term to replace suicide or more mainstream or pop culture?
Died by suicide. Not commit, because it relates to historical taboo and stigma. Unalive, no. Use the word someone died by suicide. There's all sorts of euphemisms, of course, for death, passed away, expired, gone to your reward. I was doing grand rounds on the East Coast recently, and somebody walked into the room and said, there's been a celestial discharge. That was a new one for me. But when somebody dies by suicide, part of the linchpin need of mourning is acknowledging that reality. And while we never shame someone for the use of a euphemism, somebody comes into my center and says, well, my mom passed away. I'm not going to quickly say, well, your mother died. I'm going to actually match that as part of companioning you. So when your mother passed away, what's that been like for you? Can you help me understand that? So don't shame people for it, but to say that somebody's unalive in the context of teaching about suicide grief, never heard of it, don't recommend it. Someone died by suicide. So semantics are critically important. Study the body of knowledge around the special features of suicide grief, one of which is to directly talk about how someone died by suicide. Now, if I might, I'll make a few brief closing remarks and preface that with a huge thank you to all of you who attended, and particularly for the committee that reached out to me and allowed me the privilege of sharing my passion for this area of caregiving. A final word. My hope is that together we can be a force for positive change in, sadly, the mourning avoidant culture we too often live in. Let's work to create safe and sacred spaces for people to mourn well so they can live well and they can love well. In days past, we as a culture embraced and lived the paradoxes that I introduced in my presentation. Our rituals, our customs, they supported people through the natural and the necessary experiences of grief and mourning. But as we've lost wisdom about grief and the need to mourn, and we've seen the application of the medical model to bereavement care, it has us trying to push mourners toward what I call cure instead of care. But I believe that when care becomes our priority, then there's hospitality. And Henry Now and I remind you, described it as a sacred place where a stranger can become a friend. As fellow human beings, we don't cure, but we can always care. In all facets of human life, the transformation in the last 200 years, it's mind-boggling. There's much to be proud of in our progress, but along the way, we've also forgot to hold on to much of our hard-won, ancient wisdom about loss, about grief, about integrating grief into our lives. So I invite you in closing to join me in what I call the slow grief movement that acknowledges that loss is as much as a part of the human experience as is love. It recognizes that loss changes us forever. It's normal, it's necessary, and by its nature, it's slow. It proclaims the need for people to express their grief and to be supported by their communities. It asks us to look at the part of our past and recapture the healing wisdom and the customs that we've lost. It understands that loss is love's conjoined twin and that loss is a large component of the human condition. It supports and advocates for caregiving that is as slow as the mourner needs it to be, that's heart-based, it's not head-based. I hope you will consider joining me in the slow grief movement. Again, I thank you for having me. For additional articles or information, and thank you to the hosts who will be providing my book titled When Grief is Complicated, two people who participated in your conference. If you'd like to visit our website for resources, there it is, Center for Loss. My direct email comes right here to me, Dr. Wolfelt at centerforloss.com. If you have a question I wasn't able to address and you want to drop me a note, I promise, I commit to getting back to you and trying to be as helpful as I can. Phone number at our Center for Loss, 970-226-6050. In closing, again, simple as prayer, thank you. Thank you very much for having me.
Thank you, Dr. Alan Wolf. By one more master course in 3 hours, I don't know how you can condense so much knowledge in 3 hours of workshop. Our honor and privilege to having heard you. I thank you, and I hope that we can bring you back in the next years to one more course with us. Thank you very much.
Thank you. A privilege. Thank you, Monica.